Hello and welcome. Over 21,700 cases have been now detected as positive in India. About 686 people have died. Now, on the 3rd of May, the lockdown as it stands across India will be lifted, and obviously there will be far more free movement of people and goods and services than there has been so far. Now, whether that will actually happen, we don't know for sure. But what if we were not to lift or we were not to have a lockdown in the first place, or if we were to lift the lockdown regardless of what the numbers are? What if we did not have quarantines and lockdowns to start with? What happens then? Would the casualty numbers be higher? Would they be the same? Would they be lower? We don't know. But there is an interesting theory that is doing the rounds, which questions whether we are indeed overstating the case. And it all began with an article on the 24th of March in the Wall Street Journal by my guest, Dr. Jay Bhattacharya, professor of medicine at Stanford University, also a senior fellow at the Stanford Institute for Economic Policy Research, who argued that essentially that the projections were too high and we needed to revisit these numbers or at least relook at them differently. Dr. Bhattacharya, thank you very much for joining us today.
My pleasure.
Okay, so before I sort of ask you all the questions that I'm obviously keen to ask you, tell us, so you're a professor of medicine at Stanford, and then you did an MD, and then you also did a PhD in economics. So tell us what made you go into economics after doing medicine.
I've always been interested in medicine. I love science. In school, I encountered economics, and I was amazed to find that you could use the tools of economics to understand questions in medicine in a very sort of different but very effective way, and that's why I picked both.
Right, and you follow and you focus on the economics of healthcare as a theme around the world, and that I'm assuming is what led you to form the conclusions that you did. So tell us, so why is it that you fundamentally believe that there is that we are overstating what can happen if we were to not have in India, we're calling it a lockdown. I think in the United States, you're calling it shelter in place order or a quarantine.
So I just want to correct the record slightly. I actually believe that the epidemic is more widespread than we believe, not less widespread.
Yeah.
I mean, that's my hypothesis. I'd like to see that hypothesis tested basically everywhere. Mm-hmm. And the reason I believe that for this hypothesis is that there are many people, and we're seeing this from studies around the world, who've been infected with the virus, cleared it, sometimes with no symptoms, sometimes with mild symptoms, and never were tested to find the virus positive. So those case numbers you said, 20,000 some in India, those are all cases where there's been a test done to check whether the virus is active in you.
Yeah, and in India, we are testing also only if there are symptoms to start with.
Right. It's just actually similar to all around the world. That's basically this, because why would you go get a test if you have no symptoms, right? But that means that we are missing most likely large numbers of people who have not had symptoms, have not been tested, and yet had had the virus. The only way to check for that is by doing antibody testing. Antibodies form in response to the virus and provide evidence that you actually had previously been infected. Only by doing that kind of testing can you understand really how far along in the epidemic we are. And as I said, my hypothesis is that we are very, very much further along than we can tell from just looking at the case reports. But I will agree with you on one aspect, and you characterized correctly. If we want to understand the death rate from the virus, we need to understand the size of the number of cases. We have some sense of how many people died in the numerator, but we also need to know how many people have been infected in the denominator. And that's the piece we don't know. And if my hypothesis is right, that number is much larger than we realize, then the death rate per case might also be lower than we realized.
Right. So I don't know if that really helps, that we know that the fatalities as a percentage of people infected is lower as per your hypothesis. But we'll come to that in a moment. So how are you even concluding? Because we're talking about coronavirus, which has essentially come from Wuhan in China and then spread all over the world. So why would you assume that there are far more people either in the United States or elsewhere actually carrying this virus already or for a much longer period of time?
So, I mean, that's a good question. Obviously, this is a novel virus. There's a lot we don't know about it. The hypothesis is partly driven by my work that I did during the H1N1 flu epidemic of 2009, and actually just following that literature. In that literature, the early case reports reported very, very high fatality rates. And the reason why was they had looked at identified cases in the denominator, just like we've been doing now. And I think 1-2% of the population that were infected with those identified cases in the H1N1 in the early days of the epidemic died. Later, a year later, people started to do these antibody tests, and they found out that very large numbers of people had been infected that they never knew about. And the fatality numbers went from 1% of cases down to 0.01%.
Okay.
So, I mean, that happened in the H1N1, or this sort of transformation of our view of the risk of it over a 1.5 year period. Now, it's not unreasonable to say that same kind of situation might be happening now. Now, it's a hypothesis. It's a hypothesis that needs to be tested. It might be wrong, it might be right, but the only way to find out is to do widespread population level seroprevalence testing.
Right, and anecdotally, however, I mean, if you were to look at, let's say, New York, or New Jersey, hospitals are flooded with patients. I mean, in India, it's the counter. I mean, I'm talking to a lot of lung specialists or pulmonologists and critical care specialists, and we are not seeing a surge in cases, even assuming we ignore the data completely. So, but that didn't happen in H1N1. You were not seeing a surge of patients in hospitals.
Yeah,
and
I'm sorry, I should be clear. This is different than H1N1. Absolutely, it behaves differently. And it's very clear also that the mortality from this virus, it's not just the biology of the virus, but the situation in which people who get very sick with it are treated. So in overwhelmed systems, it seems very likely, based on the data, that the mortality rate will be higher per case than in places where there isn't this overwhelmed hospital systems. So it's both the biology and the health economics, if you will, sort of acting together to determine the mortality rate from this virus. And so that's why I think it's important not just to say, I've done a study in Santa Clara, let's pretend we know the numbers everywhere. We need a study in India if we're to understand how that virus and how deadly it is and how widespread it is in India. We need a study in Switzerland. We need a study in Sweden. We need a study in New York, separate from Santa Clara. These are all very, very different environments in which people get taken care of. And without understanding the denominator, we're not going to have any chance of understanding how this virus is behaving, how deadly it is in various situations.
Right. So in Santa Clara, I mean, your study said that the actual number of people infected could be 50 to 85 times what is presently known. So that seems obviously like a dramatic number.
Yeah. So there's about 2 million people in Santa Clara. Our estimates of prevalence range from 2 to 4%, depending on statistical assumptions. If it's at the date that we did the study, there were roughly 1,000 identified cases. On the low end, our numbers suggest something like 50,000 cases in Santa Clara. On the high end, it suggests more. That means, let's say take the low end, that means there's 49,000 people who had the virus in Santa Clara that were never identified with a PCR test.
Okay. So, I mean, the other number that one hears, including from the medical profession, is that for about 85% of the people who are infected, nothing really happens. And it's really the 10 to 15% who we are worried about, and maybe the 3 or 4% who go into intensive care units and then maybe into ventilation, and then things go south quite dramatically after that. So is your theory in some ways reflecting that? I mean, the fact that a lot of us may carry it, and we by now we know people who've contracted it, only exhibited mild symptoms or maybe even severe symptoms of flu, and then it's dissipated.
Yeah, I mean, I completely agree with that. The only thing I would add to that is if we don't know it's 85% or what, because we don't know the denominator. But it does seem to have, in many cases, no symptoms at all. Right. So like in Chelsea, Massachusetts, there was just a study released a couple of days ago suggesting very large numbers of people with antibodies. There have been studies now done in prisons where they find the virus active in people, and most of the prisoners don't have any symptoms at all. On the other hand, the virus is also deadly, as you say, in many cases. It presents with the severe viral pneumonia, especially in older people or people that are vulnerable. So it's not that we should take the virus less seriously. In fact, I think we should take it more seriously. We should better understand what its property, who's at risk from it, how extensive it is, and then make better decisions about what to do about it. As opposed to now, I think to some extent we're making decisions in the dark. In fear and in the dark, and I think that's my main call. Is let's shine the light of science on this. Let's actually get better numbers so that we can make better decisions.
Right, and I'll come to how to get those numbers. But how do you, explain some of this? I mean, you talked about that study in Massachusetts or the study from prisons, and how people are behaving quite dramatically differently. So, what explains that?
I mean, as I said earlier, I think there's obviously still a lot we don't understand about this virus, but I think it's very clear that it's not just the biology of the virus that makes it deadly. It's the circumstances in which you get it, the circumstances of the healthcare systems that are managing the people. All those things combine to determine what happens to people that get sick with the virus. Okay,
so your path or way forward is to test, obviously, and then you find out. So how do you test, and what is the scale of testing that you propose that, America should do, or other countries who are trying to get a better grip?
Every country, India should do this too.
Yeah.
I think that so a lot of people, when they talk about testing, they're talking about the testing for the active virus in you. It's called a polymerase chain reaction test. It's actually, the virus is an RNA virus, so first you have to do a reverse transcriptase and then put PCR. That test just checks if you have it right now. After you get clear of the virus, you'll be negative. What we need is these antibody tests. Yeah, but we don't need to, for this kind of population surveillance, we don't need to test everybody. We don't need 1 billion plus people tested in India for this kind of surveillance. What you need is random sampling of the population. And so you look at areas, let's take Mumbai. We can divide up Mumbai into various parts, and then randomly pick people from those from each part, and it doesn't take very, very large samples. Thousands, 2,000, 3,000, 4,000, 5,000 samples, and then you can get a very good idea about the spread of the virus in populations that reflect millions. The tests themselves are inexpensive. These basically many of them just require a finger prick blood sample. There's been a lot of controversy over the accuracy of these tests.
Yeah.
So there's two kinds of accuracy in these kinds of tests that are really important to understand the difference. So the first kind of accuracy is called specificity. Specificity. What that means is the rate at which a negative case, someone who's truly negative, ends up negative, right? So it's kind of related to the false positive rate. That has to be very low, it turns out, for epidemiologic studies. There's also another number called sensitivity that says, if you're positive, how likely is it I'm going to find you to be positive? The cheap tests are very, very specific, but only somewhat sensitive. But that's actually fine. As long as you're very specific, it's great for epidemiologic work. Because just to give an example, suppose I have a test that's only 50% sensitive. Well, that means that every positive I see, there's one other out there I didn't see, false positive out there. But I can adjust for that statistically very, very easily. These tests are actually ideal. The ones that are the cheap antibody tests, it's actually inexpensive to do this kind of population survey work relative to trying to test the entire population or to shut down an economy or something. We should just do these. I mean, there's no good reason not to have these studies basically done everywhere.
So, and then the economic conclusion. I mean, would that be that we should not be therefore fretting too much about lockdowns and quarantines and open things up?
I don't know the optimal policy until I know these numbers. It's really hard to say. I think one outcome I'm hoping from this work is that we will quell the fear. Right. So if I believe that when I get the virus, or if I get the virus, I have a 3% chance of death, I'm going to be very scared. Right. I mean, that's essentially what the World Health Organization said was 3% mortality. On the other hand, if it's 1 out of 1,000 or 2 out of 1,000, I'm going to be much less scared. I think making policy in the midst of fear is really, really a bad idea. And now there may be reason to fear. As I said, it's a hypothesis, and we need these numbers everywhere. But if we're going to do that, if we're going to reason and think about policy in fear, it better be well-grounded fear, not fear based on not knowing what a number that we could very easily get is.
Right, and in a way, you represent both worlds. I mean, to answer the next question, which is, in India, where even the Prime Minister has said that, it's lives versus livelihoods, and it's the same debate everywhere.
It's not just livelihoods, though. It's lives on the other side. People talk about economics as if it were a secondary thing, but it's actually lives. Poorer countries are deadly, especially for the poor people living in them. Mm-hmm. The deaths from the other side of this policy, the shutdown policies, lockdown policies worldwide, will create, we're already in it, a devastating global economic depression. That depression will kill people, large numbers of people. It's only a question of who will die relative to the COVID. On both sides of this policy, there are deaths. It's not dollars for lives; it's lives for lives.
Okay, but are we any closer to knowing in which side the balance is tilting today, or we obviously have to wait?
My numbers. I need zero prevalence numbers. I've been saying this from the very beginning. We can't really answer the questions you're asking me with any confidence until we have those numbers. It's the start of a reasoned policy. We've shut down the world economy, and almost certainly that it has saved lives from COVID. Absolutely. Slowed down the rate of growth of disease. It's probably one of the reasons why the Indian numbers are as low as they are. They sound horrifically high, but as low as they are. They would have been higher if the lockdown had not happened. Absolutely. So we know that, to some extent, the benefits of the policy, but we have not made any effort whatsoever to measure the costs. And I'm not talking about the economic dollars cost. I mean the lives cost of the global economic depression that's about to hit.
Right. Last question, Dr. Bhattacharya. This is it's a novel virus, and it's something that, as in the way you put it, it's crept into our lives and our existence silently, much earlier, perhaps. Not so easily quantifiable by saying there were so many 400,000 people flew in from mainland China to the United States, and therefore that's how it spread. So what does this tell us about viruses and about pandemics and lives as we will lead them or likely to lead them in coming months and years?
We face the risk of death from a vast number of pathogens every single day. Mm-hmm. It's just the nature of human existence. This is going to be one more, I think, at the end of the day, that we'll just have to cope with. And hopefully we'll learn more about it so we can treat it better, treat people who get it better. We can learn how to prevent it. Maybe there'll be a vaccine. So I think all those things are good, and they're coming. My fellow scientists have been doing amazing work. And I look forward to that. But in the meantime, we shouldn't destroy the world economy and kill. I saw a story in the New York Times the other day about 500,000 deaths from starvation in children worldwide, projected from the global economic collapse. Do we really want to act so that I can protect myself at the cost of these 500,000 children without actually having the numbers to reason about it correctly? I think that's really the case I'm making. Let's get the numbers. Let's get the real numbers and then decide what the right thing to do is.
Professor Dr. Jay Bhattacharya, thank you very much for talking to us, and pleasure hearing your views. Thank you so much.
My pleasure. Thank you.
Bye.